Guys. My name is Brian. One of the senior clinical fellows at Stockport NHS Trust. So what we're just going to discuss is some of the cases that could come to you, either in clinic or you'd see them in the accident and emergency department or during your rotations. So things that you should be aware of, things to look out for. I know most of us have a certain fear when it comes to eyes, and it's a known fear, and it's valid. And the reason for this is usually because we have very, very limited time when it comes to ophthalmology rotations during medical school. So hopefully, after this interaction, you'll be more confident. And you do not have to be an eye surgeon to be able to feel confident about eyes, because all you need to be able to identify is who needs immediate care, who you can be able to, who among the patients that you're seeing you'll be able to manage and discharge home safely, whom among the patients that you come across, you'll need to then call the ophthalmology reg or call your seniors and say, I think this one needs a further review, more input is needed from above. Anyway, so, and I'm not talking about the fear that is ometophobia. This is just the fear that people of the unknown, really, because you're not really confident in dealing with the ophthalmology kind of patients. So we'll go through a few case scenarios. And the first one is what I call, it is a medical emergency. So it's one of the common medical emergencies that you'll come across, whether in your wards, in clinics, in rotations, in accident and emergency. So in this case, there is a 72-year female who presents with sudden painless blurry vision in one eye. Let's say it's either the right eye or the left eye, so one eye. And in their past medical history, you find that they have hypertension, and they report that this has been well controlled. They've been taking the tablets well, and it's being monitored regularly, both at home and by the GP. And as you dig further into the history, you find that they're reporting a little bit of hip stiffness that has been ongoing for the past, let's say, 2 or 3 weeks. And they also report persistent right-sided scalp sensitivity and a headache. And one of the things that I would really, really impress upon you is always try and check visual acuity. I know it's not difficult, and in the era of smartphones, you don't need to have a formal Snellen chart with you. You can just Google and find a Snellen chart equivalent on your phones, and you'll be able to at least assess the visual acuity. So their visual acuity will be reduced on that side. And you check pupils and you find that the patient has relative afferent pupillary defect. So let's get into it. What should be high on your list of differentials? What would you think? You can
there's chat box you can monitor.
Yeah. So excellent. Yeah. So most of you have actually said that, yeah, it will be temporal arteritis with visual symptoms. And I agree. So these are one of the main things that you'll see, and you really, really need to take honors of the patients, rush and do your bloods, make sure that the bloods are sent out urgently. And because the patient has visual symptoms, you want to kickstart treatment as soon as possible. You might request a temporal artery ultrasound, which has been shown to be quite good in picking out temporal arteritis. Although the gold standard is doing a temporal artery biopsy, with a temporal artery ultrasound, you can still make a concrete diagnosis and say this is actually temporal arteritis based on symptoms, based on the examination findings. And at this point, you want to talk to your seniors, talk to whoever is holding the fort, and make sure that the patient is started on steroids as soon as possible, because the main aim of starting treatment is to save whatever vision is still left in the affected eye, but also to reduce the risk in the other eye. Because studies have shown that at least 30 to 50% risk of the other eye being affected. And if treatment is not started as soon as possible, then they might still develop arteritis affecting the other eye, and that means that the patient is now permanently blind. Now, this is another case, which I usually call a sick red eye. So you have a 60-year-old female who presents with nausea and vomiting, and they have severe unilateral headache. And they are also reporting on that side that the eye, when looking at lights, they appear to have halos around them. You check your visual acuity, you find that it's reduced, or they say that the vision is blurred on that side. The conjunctiva on that side is hyperemic, so it's a red eye. You find a hazy cornea, and the reason for the hazy cornea we'll find out very soon. And the other thing to check is your pupils. You find a fixed and mid-dilated pupil. So something almost similar to what we can see there, which is on the right side of your screen. So you see a mid-dilated pupil. You can compare the pupil size on both the eyes. You can see that one is mid-dilated. The eye is hyperemic. Cornea is not that clear, and the patient will be in quite painful distress. So in this patient, what will we be thinking about? We see you can just type whatever you think is going on in this patient.
It's got a few responses in the chat box.
Yeah. So for this patient, is what we're thinking about is an acute angle closure, okay? And one of the ophthalmological emergencies, but they will present to A&E. You'll come across them, and they might present even in the ward. They might have come in with something totally different, and they end up having an acute angle closure whilst in the ward or whilst having treatment for something else. So you need to take precaution, be very vigilant about these patients, be very vigilant about this eye, because most often than not is you find that if one eye has had that shallow anterior chamber, that risk of having an acute angle closure, then the other eye is also at risk. They might develop it in the other eye. So just to take precaution and start treatment as soon as possible. But most importantly, call the ophthalmology reg to come and sort out the patient. Okay. The other case is what we would call a silent red eye. So you find a 20-year-old female, 1 week history of bilateral redness, gritty sensation, discharge, and in the past medical history, nothing really. They say they are fit and well. They have good vision, and they have a mucoid discharge when you examine them. So what would you be thinking about in these patients? So, yep. So pretty common as well. So common things occur commonly. So this is just a conjunctivitis episode that the patient is having. And usually the vision is usually good. If it's reduced, possibly just a tiny bit, they might have either mucoid or mucopurulent discharge, depending on what the causative organism is. If it's viral, it will be watery discharge anyway. So they will be having a bit of a discharge there. And this is some of the cases that you will feel confident to see them, assess them, manage, and safely discharge them with the advice that if things get worse, they can still come back and get further care. Okay. Now, another silent red eye that you can come across is this case where you have let's say a 28-year-old male with a 48-hour history, and they present with redness and a deep, dull ache, which is affecting one eye. In some cases, it can be both eyes, depending on what the issue is. And then they also report that they have been extremely sensitive to light over this period of time. Once they started developing the symptoms, they've been fit and well, except for a history of lower back pain and stiffness for the past 4 months, and reduced vision, which they report as misty. And then you have this redness, which is very classical, which we call ciliary injection, which is around the cornea, and you have a small irregular pupil. In some cases, the pupil might just be normal, especially in the early stages. So for this patient, yeah, I can see people have already put it on the chart there. You're thinking about anterior uveitis or iritis, and those are things that you need to be aware of. So as you can see, you can either have a red eye, which is, you can see the patient, it's just a conjunctivitis, see the patient, sort them out, discharge home with good advice to come back if they need to. If it's a case of a uveitis or iritis, you know to refer to the ophthalmology reg to come and take over, or the ophthalmology team that are within your vicinity. If it's an acute angle closure, obviously still refer to the ophthalmology reg. So there's several key differences that we should be aware of when you're thinking about just the conjunctivitis and the uveitis. For the uveitis, vision is usually within reasonable standards. It's not, might be still reduced, but within reasonable standards. When you think about the acute angle closure, the vision is usually reduced, markedly reduced. And that's to do with the hazy cornea because of the pressures the cornea is hazy, so vision is definitely affected. And also the optic nerve is not fully functional because of the pressure being applied to it. When it comes to just a conjunctivitis, vision is good. They might have discharge with a conjunctivitis. In uveitis and angle closure, you might have a bit of a watery discharge, but in some cases you might just have a normal eye, no discharge. Okay, and other thing to look out for is the systemic symptoms. For an acute angle closure, like we noticed in the first case, the patient will be having nausea and vomiting, the extreme distress, pain. So things just to look out for and keep your mind alert when you see such a patient. This is what you should be thinking of first. Okay. So we have another case where a patient, 75-year-old male, who presents with sudden painless loss of vision. And they report like a curtain came over their vision and the vision is now down compared to what it was probably when they woke up that morning. You check the visual acuity, you find it's reduced. You have relative afferent pupillary defect when you check the pupils. And you have a look at the fundus if you're able to, and you see something like that with a cherry red spot. This is what it's called. You see how pale the retina is. You can see the blood vessels are not well perfused. Something that we call cattle tracking or box scarring, where you can see segmental blood flow along the blood vessels. You can see how pale the retina, the optic nerve is. So that's what would you be thinking about in this case? Yeah, already on the chart there. Yeah, central retinal artery occlusion. Yeah. So for these patients, straight away, you need to treat them like they're undergoing a stroke. But this is a stroke limited to the eye. But because of the risk factors and any other thing that can then result from the risk factors being associated with this, then you want to do a thorough workup, do carotid Doppler to check the carotid flow, do an ECG, talk to the ophthalmologist. They'll always help. Check the other cardiovascular risk factors, make sure everything is optimized as well. Now, in the last case I would possibly talk about is what we call a post-op disaster. This is a patient who had uncomplicated cataract operation, possibly 3 days before. They come into A&E and they're complaining of excruciating pain in the same eye that they had the operation. There's redness, and you can see their discharge, and the vision is reduced. You can see that layered inflammatory cells in the front part of your eye. That's what we call a hypopion. And that's a suture there. That's a stitch at that point there. So this is definitely endophthalmitis. And any post-op pain in a patient who has had intraocular surgery, definitely consider it as endophthalmitis until proven otherwise. And just some few do's and don'ts when it comes to these patients, ophthalmology patients. When it's a chemical injury, check your pH and irrigate fast. Don't bother doing the visual acuity first before irrigating, because the longer time you take waiting for to check the visual acuity, to check the pressures, to do all these other things, the insult is still going on, whether it's acidic, whether it's an alkaline. So check the pH, irrigate, and recheck the pH. And then for penetrating trauma, For these patients, you'll find like a distorted pupil. So for this patient, try and avoid putting drops in the eye. You can give an antiemetic and a pain relief because as they continue having any episodes of nausea and vomiting, then that internal pressure causes also further loss of contents from the eyeball if it's a penetrating open injury, open globe. So an antiemetic and pain relief would be good. Put an eye shield and call the ophthalmology reg. They'll come and sort it. Okay. So things to look out for and things that you need to call the ophthalmology reg about. So if you have sudden vision loss, if your patient has severe eye pain, especially post-op, if you have suspected orbital cellulitis, and there have been several cases of orbital cellulitis, or is it necrotizing fasciitis? So many cases of necrotizing fasciitis that go missed, and they end up with poor outcomes. But yeah, so if you suspect anything that could be potentially catastrophic for the patient, just call the ophthalmology reg to come in and give their input. And also check pupils. So I would tell you, invest in a good torch. Check your pupils. If you find a fixed dilated pupil, if you find a distorted pupil, get advice from your seniors or from the ophthalmology reg. And as a summary, I've said this again, check your visual acuity. If it's post-op pain, it's endophthalmitis until proven otherwise. And for giant cell arteritis or arteritis with ocular symptoms, it is a medical emergency, so try and sort this as soon as possible. Okay. Any questions, discussions, any suggestions, anything you'd like us to discuss, you can let us know.